Respected teachers, my teachers who has taught me all this, and good afternoon, all my dear colleagues. And coming to the primordial prevention of diabetes state, I know this you would have heard already, but still we want everybody to take up to know enjoy the fruitfulness of it, because we are doing in so many places, and we are finding for the past 2 days you would have been hearing such a lot of things on cardiovascular system, MAFLD, and whatnot, dyslipidemia, obesity, metabolic syndrome, all these. If you want to take away all from its roots, focus on the fetus. That's what our mentor, this is nothing of mine, this is the pure concept of my mentor, Professor Dr. Seshia. And coming to why treat GDM, if you take the recent Lancet, that what Dr. Anjana, Dr. Mohan has published in Lancet, it has been told that diabetes, it's not a single disorder, it is associated with all this. See, pre-diabetes, who are going to become diabetes is more than diabetes, and see the dyslipidemia, hypertension, it's 3 times more, though we are not concentrating, giving much importance to that, which is more dreadful. It's 3 times more than diabetes, and usually all these are generalized obesity, abdominal obesity, hypercholesterolemia or high LDL, all are associated comorbid conditions along with diabetes, but this diabetes is a single, don't think this is a single entity. And if you want a diabetes-free generation, that is, you want to grab not only diabetes, all the non-communicable diseases from its roots, you have to focus on the fetus. And why we say that? If you take the pathophysiology of gestational diabetes, it is nothing but insulin resistant and hyperinsulinemia, which is the basic pathology in already existing women, and it drives the metabolism of the, drives all the metabolic development of all metabolic disorders by affecting the placental growth, angiogenesis, lipid metabolism, all that. And this response, that hyperinsulinemia, is initially from the mother, but what happens later, it is taken over by the fetus. See, whenever the mother has high blood sugar and insulin resistance, she has this high blood sugar passed on to the fetus through via the GLUT4 and GLUT1 transmitters. And what happens, there is increased insulin secretion in the fetus. Initially, the maternal insulin affects the placental growth, angiogenesis, all that. Later, it is taken over by the insulin from the fetus, and this hyperinsulinemia does not stop with that. It further continues, causing fetal exhaustion and type 2 diabetes later in life, and causing cardiac hypertrophy and cardiovascular diseases, and causing fat deposition and obesity, and also impairing the hypothalamic development and leading to effect on the feeding behavior. So, remember, our teacher's teacher, Professor Sam G.P. Moses, always used to say that maternal hyperglycemia and fetal hyperinsulinemia are the kingpins of pregnancy metabolism. And these both have a common soil hypothesis. That is, the basic is insulin resistance leading to hyperinsulinemia. And this is the one causing impaired glucose tolerance, hypertension, dyslipidemia, abdominal obesity, both leading to both type 2 diabetes as well as cardiovascular diseases. And this has evolved from generation to generation, and what we saw in our days, that is in 1991-92, it's not the same. Now it has got transmitted, and we are finding more and more cases of GDM because of the transmitted transmission through generations. And if you take female gender is the key for diabetes prevention, we can say NCD prevention. How David Barker has long said that body's susceptibility to lifestyle diseases all is programmed intrauterine. That is, from morning you would have heard, even my previous speaker, Professor Dr. Ramchandran, was saying that intrauterine programming is important. It's a process whereby any stimuli, it may be maternal fuel, undernutrition or overnutrition, whatever may be, which when it occurs during this critical period of development, it permanently affects the structure, physiology, metabolism, and predisposes the individual to all diseases later in life. This is the fetal origin of adult diseases. And David Metzer, again, he has said, if there is fetal hyperinsulinism, the baby has obesity at a much younger age, that is at 5-6 years itself, and most of them, almost 1/3 of them, 33% of them developed IGT, impaired glucose tolerance, pre-diabetes. You can find even in your practice children who are obese, you can test and find out this pre-diabetic at a very younger age, school-going ages. And if they have normal fetal insulin, of course, they don't put on much weight, no obesity, and also only 1/10 of them, they go to develop impaired glucose tolerance because of the environmental changes. And if you take the pattern of glycemia during normal pregnancy, this is not a study of 1 year or 2 years or 10 years. Hernandez, after studying for 40 years in 12 centers around the world, he has found that the fasting is always plus or minus 71, 71 plus or minus 8, and 1 hour is always less than 122, and 2 hour is 99 plus or minus 10. This is the normality in non-diabetic pregnancy. So, having this in mind, our mentor wanted to test all pregnant women, and you all remember that in pregnancy, blood sugar has to be tested, has been first given by Professor Dr. Seshia, and it started from Tamil Nadu, and all other states followed Tamil Nadu, saying this as Tamil Nadu model. And again, he gave a very simple procedure. I have gone into all the rural centers and I have found how many of them, I have studied this in almost 5,000 cases, and how many of them are coming in fasting. Very few, less than 10% were coming in fasting, and that too they were asked to come for fasting for some other reason. Otherwise, definitely when to come the rural centers where the cases are overloaded, they always come in non-fasting state. So, having this in mind, he came out with a single simple test that it can be done either in the fasting or non-fasting state with a simple 75 grams of glucose in all pregnant women, irrespective of the risk factors. You have to do it in all women, because as I said, it has all become paradigm shift. It is not like those days. Now everybody, you can see many are insulin resistant. So don't leave any woman untested, and we were doing this test for all the women and finding them, catching them, and putting all the management. If they touch or cross 140. And what happened with controlling the GDM, what we had, of course, we were able to control preeclampsia, which is again a state of insulin resistance. Preterm was controlled, big baby, UGR, all were controlled. But we were not able to control the childhood obesity, which is very common nowadays. The early occurrence of impaired glucose tolerance, future diabetes, and other non-communicable diseases, they are all continuing to increase. Now, our father of GDM, Professor Dr. Seshia, has come out with the concept of primordial prevention of diabetes. That is, diagnosing GDM is very easy, and what we are concerned is prediction of GDM. That is, we want to prevent the development of GDM and its consequences. We have to start well ahead. What we heard in the morning that Dr. Lakshmi and Dr. Jayashree was saying, that it is fitness to conceive. It has to start in the adolescent age and catch all these problems and bring it under control before they conceive. And what they said is, before marriage it has to be controlled. That's true. And when to test to predict this GDM is, NIH has told that it is in the first trimester, that too at 10th week. Why this 10th week? If you see the development of fetal beta cells, it starts functioning by 11th week. Once this function starts, it is irreversible. It will never stop. So what happens? And why this happens? If you take the fetal renal threshold, it is 110, like what we have 180. For the fetus, it's 110. So whenever the mother's blood sugar crosses this 110, it starts secreting insulin and starts controlling the mother's blood sugar. And this fetal secretion starts almost at 11th week. So we need to, and as I said, it continues throughout gestation and also in the future. Here you can see clearly that whenever the glucose crosses the placenta, it stimulates the insulin secretion and does all this, that is increasing the adiposity and what all I said. See, the mother's blood sugar, it's actually high, but it's brought down and it looks normal at the cost of hyperinsulinemia in the fetus. So this fetal hyperinsulinemia is likely to present before the GDM diagnosis, what you usually do at 24 to 28 weeks. And what happens, there is fetal glucose steal as long as it is inside the mother. And this increases the risk of false negative GDM results. Many OGCNs, they'll come and say, the blood sugar is very much normal. How come we had the preterm delivery, or they developed preeclampsia or big baby? All they used to ask, this is because of the fetal handling of the maternal blood sugar. And for example, if you see a lady at 10 weeks with a blood sugar of 126, and at 12th week it has come down to 112 without any intervention, what has happened in between? In between only, as I said, the fetal insulin secretion has started, and it started controlling the mother's blood sugar. The maternal blood sugar does not go up due to the fetal insulin handling of the maternal glucose, and whenever the maternal blood sugar crosses 110, immediate action has to be taken to bring down this less than 110, otherwise she'll develop GDM and its consequences. And as I said, this initially helps to bring down the blood sugar. Later, it's not, it will, as I said, it's not going to come down, and it will steal glucose from the mother as long as it is inside the uterus. And after delivery, you have heard of recurrent hypos in some fetuses because of this. And as it grows again, it puts on weight, obese, which is irreversible. We cannot bring down that, and all the non-communicable diseases later. So prevent diabetes and NCDs. We should not let this fetal hyperinsulinemia to happen by controlling the mother's blood sugar before starting of the insulin secretion. And we know that postprandial blood sugar is the hallmark of gestational diabetes and is linked to macrosomia and all other adverse perinatal problems. And whenever you see this blood sugar between 110 and 119, we do it at 8 to 10 weeks of pregnancy. This will help us to identify all women who are going to develop GDM in future. And 8 weeks, why we do? Because we have some time to bring it down less than 110 before 10 weeks, so that the fetus is not exposed to 110. Like how we prepare for the exams well ahead, not just entering the exam. This again has showed that hyperinsulinemia in the mother, it affects the male child also by producing infertility. We are now facing a lot of infertility. It affects both the male and female. Again, as I said, for prediction of GDM, 110 at 10th week shows that she will become a GDM. And to bring down this blood sugar less than 110, preventive actions has to start at 8th week. And if the postprandial is between 110 to 119, start with metformin 500 half BD. Why this 119? 120 if it touches, it's already GDM. We have to start treating by putting either on medical nutrition therapy or metformin. The priming of the fetal beta cells around this 11th week may account for the persistence of fetal hyperinsulinemia throughout pregnancy. As I said, it is irreversible. Again, as our speakers said in the morning, that metformin is safe, and this is the only anti-diabetic which can be safely used from conception to birth. It not only reduces the GDM but also reduces the pregnancy-induced hypertension and preeclampsia, which again is a feature of insulin resistance. And this again we have done studies at 3 centers, dividing the pregnant women into 3, that is those less than 110 not developing GDM much, that is 2 to 4%, above 110, 80 to 90% of them developing GDM. The third group, we have put them on intervene with metformin. Again, the incidence comes to less like what we saw in less than 110, that is the less than 5%. This we have proved at Delhi, Chennai, Kanpur, and again at Bhopal it is undergoing. So what is the classification? If it with glucose, if it meets or crosses 200, it is diabetes, and more than 140 to 199, it is GDM, and 120 to 139 itself is gestational glucose intolerance, and this 2-hour PP, postprandial, it's not with glucose. Postprandial, if it is early glucose intolerance or early gestational hyperglycemia. Any value above normal is abnormal. So just one blood sugar at 8th week of pregnancy, it's postprandial 110 and above. Please start treating with metformin, and thus, GDM is the window of opportunity for prevention of all the cardiometabolic disorders. So, our Professor Menta says that to achieve a diabetes-free generation, we have to focus on the fetus in the future. And to this short term, care during the pregnancy gives long-term benefits for both in the child as well as the mother. Thank you.
Thank you, Dr. Bhavatharani.